Well, welcome everyone. We're back in PACA 2 and we're back now and the spring season is ending for us or getting close to the championship time. And I felt that this would be a good time, and several of you had asked about having Dr. Saxena on to go over some of the little aches and pains that some of our athletes are feeling right now and how we can either hang on to them through the season or be more preventative as we go forward. Dr. Saxena is one of the top doctors, podiatrists for athletes in the world. I mean, we're very honored to have him. And again, his son VJ is one of our regular contributors, so that sure helps too. But Dr. Saxena has been up in the Northern California area. He's worked on Olympic level athletes and professional athletes of all different sports and everything. Dr. Saxena, what got you into sports and podiatry to begin with?
I was an injured runner and got treated by sports medicine doctors, and then I got treated by a podiatrist who was in the 80s. Podiatrists were treating a lot of runners, getting them back running, so that's how I decided to do that. So,
Oh, nice. Okay. Well, great. Well, you've got a presentation for us here, I think, and then if it's okay as we go on toward the end to answer any questions that our coaches might have for you.
yeah, okay.
Great.
Yeah, so I've been in Northern California for 36 years in Palo Alto, primarily at the Palo Alto Medical Foundation, but I've actually moved on. I'm moving to a new group called Bass Medical. I'll basically be private practice still in Palo Alto. My tagline is born in Palo Alto. I'm staying in Palo Alto. And yeah, I'll have all the toys that I use for treating athletes and be able to continue doing it, or at least plan on it for the next 5 years. Some athletes told me not to retire till at least after the 2028 Olympics. So, but yeah, I'm going to talk about some common injuries. I want to honor Brooks Johnson, who had a lot of great quotes. I gave his wife Betsy a bunch of them that I remembered, but one of them was "Sweat the small stuff; the big stuff will take care of itself," and the other was he told me very early on. I think the first year I came back into practice, he says, "When you tell a coach their athlete has stress fracture, you just told them they messed up." Of course, well, Brooks used the little bit more colorful word. And so I've known Brooks since I was in high school, actually, when he came to Stanford and interacted with him and his athletes over the years. I'm grateful for him to have introduced me to some of the Olympians and that I ended up operating on or ended up being Olympian. So he's a big, important part of my life and obviously VJ's life too. I've got other coaches in my life, good friends. Mark Coogan, and who's been really successful, and of course VJ, and then my high school coach is still out there coaching with my wife. They're the co-head coaches at our high school, Gun High School. So coaching is an important part of my life. I'm actually a certified coach as well as an official. I write the workouts for the distance runners. Um, so I'll talk about why coaches get upset when their athletes are injured. Well, first of all, you got to accept it as part of life, just like taxes, and you can't succeed all the time. And because it's the reality, you got to kind of check your ego and reputation and do what's best for the athletes long term. Um, it's the same thing with doctors too, and then just try to get your mindset on focusing, getting them better, getting the athlete better, and sometimes for athletes, sports psychologist is helpful or some type of psychology because pre-op anxiety, at least, is correlated with negative outcome with surgery in case they need surgery. But pre-op anxiety in general, or anxiety in general, is associated with a lot of chronic foot and ankle problems. 80% of patients with chronic foot and ankle pain have higher levels of anxiety and depression. So you've got to recognize that, and there's some resources out there that you should use. I've got some on my website as well. And certainly during the COVID generation, there's higher level anxiety about injuries and just about everything. So what is an injury? Anything that's more than a 3 out of 10 on the 0 to 10 pain scale, which I'll show you. Pain accompanied by swelling is never normal. pain that gets worse with activity is not normal, and limping is never normal. So if you got any of these signs, the athlete's injured and they need to get it addressed, they need to get it diagnosed and get a treatment plan. And the higher level the athlete, the more, the faster the urgency is. But even in high school athlete during track season, you miss 3 weeks, you're done. So you kind of need to get into the medical mainstream as fast as you can. And I make my practice available to athletes within 48 hours. That's just what I've always done. I've had a soft spot for injured high school kids. So we try to get them in. I try to work with the trainers. The trainers have a lot of control at a lot of different levels, and they're not always right, and they don't always reach out. So hanging on to the patient is not a good thing. You got to get the right diagnosis to get the right treatment plan. This is that 0 to 10 or VAS score, so you can use that. And again, anything above a 3 is not good. So. This is a return to running schedule. I don't expect you to read it and memorize it, but on my website, which is getting updated, it's just my name, amolsaxena.com. I've got a whole return to running program, and on that program, it tells what the parameters are if you can run. And people following this program have never say never, have never been injured, getting back on this ramp up. But when they get cocky at week 3 or 4 and decide they want to do intervals or hills or something, that's when they deviate or get out of the off the lane or off the track. So you need to follow this. This has been tried and true for about 36 years. So a lot of coaches, high school and elite, use this to return to running. And how much should runners run? I mean, young runners, Jeff Atkinson has this formula that he's used pretty successful. He's coached 2 state championship teams. He was Olympian, of course, and high school freshman. He's got the mileage down there and the ranges. Their ranges, of course, if you got a mature kid, you can run a little bit more. If you got an immature kid, you run a little bit less. And but these are kind of what we try to shoot for and not go beyond. So a lot of myths in medicine. You can probably think of some like drink water when you're dehydrated. You don't drink water when you're dehydrated. You drink electrolytes. And so stretching, there's no scientific proof that prevents injury. So many people stretch all the time and they still get injured. Stretching helps increase range of motion. Stretching helps warm up, but it does not help preventing injury. The 10% rule is also a myth because if you start out with 1 mile, you're not going to run 1.1 mile. Let pain be your guide. I never say that to a runner. I've had runners run with broken bones. Some people just think that plantar fasciitis and Achilles tendon problems will get better in a year, but that's not always true. One study showed Achilles tendonitis or tendinopathy, we call it. Only 20% of the people get better in a year by just kind of doing the watchful waiting thing, stretching. And then a boot rest, people just keep throwing people in a boot. And my quote is, if you're in a boot and nothing's torn or broken, you need a different diagnosis or a different doctor. Um, I have a new quote. If you're getting an hour of massage a day and you're not getting better, you also need a different diagnosis or different doctor. So. And then the terrible twos, too much too soon, 2 different changes, increasing your mileage or shoes is pretty common. Different heel drop, different type of configuration. I'll talk about the carbon plates, different surface, different intensity. And then avoid peer pressure. We're seeing this more and more with Strava. Kids like to post how fast their workouts are and look what other people are doing. So with social media, this has become even more of a problem. And then I want to talk about some of the technologies because shockwave is something that there's a lot of confusion on. There's basically 3 types. The most common one is radial pressure wave, which is about what 90% of the machines are in America. And they're helpful for certain things. The real shockwave is something called focused shockwave, which goes deeper. And then there's a new type called EMTT, which is electromagnetic field that is out there. It's been out about 3 years, and that really helps in different things I'll talk about. And they all work differently, but sort of synergistically. Sometimes you combine two or three of them. Basically, they all work by increasing blood supply or angiogenesis and stem cells and growth factors. So they help promote healing or restart the healing process that's not normal. When you have degeneration in your tendons or overworn joints and stuff, or acute injuries, you need to stimulate a healing response. So all three of them work different. It has the highest level of evidence of anything you do. Unfortunately, a lot of people don't have it, so they don't recommend it. I see athletes all the time that they're just putting boots and try this and this, and if that doesn't work, you either give up your sport or you get surgery. And it even helps wound healing. There's a lot of potential for this. And it's non-invasive. A lot of times there's no downtime. If you're running, able to run, you can keep running. And they even treat some athletes during halftime in Europe. And Henrik Ingebrigtsen, you guys know who Jakob is. Henrik, his older brother's coaching him. At the Olympics this summer, I had 10 athletes run and three win medals, two golds and one silver. Henrik said, I cannot imagine being an athlete in this time without the availability of shockwave. So that's a pretty strong statement. And a lot of the elite athletes, elite teams now have some form of shockwave at their disposal. Some of the pro teams have the radial ones. Pretty much none have the focus. They have availability to get it from doctors, but those are 70,000 plus machines. So, and then EMTT is that new type of shockwave, and it helps recovery. So some teams have bought those, and that's actually kind of a game changer. And there's a lot of articles. Adam 1040's former patient and runner at Stanford, and then became a great doctor. And he does a lot of research. And I've worked with him on some stuff, and he's published a lot of good articles that you could share with your trainers if they're willing to read. This is one specifically on bone stress injuries or stress fractures. Um, that we use it on stress fractures. We use it on Achilles and plantar and a lot of other injuries. And what you need to do is adjust the mindset and the time frames. People think that shockwave is the last resort, but actually early intervention works better. I'm still trying to find the paper, but there was an article showing if you treat areas that have been previously injured, like say you had Achilles tendonitis last track season, if you pre-treat it before the beginning of the season, you're less likely to have a recurrence of that. And so you don't have to wait 3 months. Some athletes have it. A flare up of something, then they just get the treatment right away. It's not covered by insurance, so what's the big deal about waiting? Why not just get it done now? And then athletes always want to know how long will they be out for, when they get back to sport, what the downtime is, and then some conditions like surgery for Achilles and navicular have a long downtime, so we try to get them on the shockwave so they don't need surgery. So plantar fasciitis, very common. It's your arch ligament that attaches from the heel, goes out to your ball of your foot. It hurts first thing in the morning, the beginning part of the run, stretching and rolling in a frozen water bottle and adding some kind of arch support or a more supportive shoe are the first line of training. Sometimes the carbon plated shoes will put stresses on your foot in a different place. I'll talk a little bit more in detail later on. So be wary of the carbon plated shoes. And then shockwave is actually the highest level of evidence or the most effective treatment you could do for it. And then if you can't run at all, sometimes we do a cortisone shot still. If you're not running at all, it's okay in the more acute cases of plantar fasciitis to do a cortisone shot. But you can't run for another week. Otherwise, you can rupture it if you run within a week of getting a cortisone shot. And then strengthening the foot is really important. There's something called a blackboard. Comes from Germany. They're knockoffs already in the United States on Amazon. And there's different type of training, strengthening things with doming the foot. Spiral dynamics is a European technique that I had a guy bring to the United States, and we've shown some athletes how to do these strengthening exercises. So you can, use these resources with your training, athletic training staff. Hopefully they want to learn. MRIs are give a lot of false positives. This is a elite athlete and it's 2 weeks away. He already had Shockwave. Shockwave helped him get back training full on. And then 2 weeks before the Boston Marathon, he ran a half marathon on cobblestones and flared it up. Didn't feel a pop, but was quite painful. And the MRI shows inflammation as if there's a tear. But if you have Shockwave, you will have increased inflammation. Shockwave creates inflammation, so it can give you a false positive of a tear or a stress fracture. So you have to go by the symptoms. The problem is a lot of doctors go by the MRI and they rely on the MRI report. And this is where the clinical experience is really important. I gave the green light to get an injection in this case because I knew it wasn't torn, and he got it. He got the injection. He was able to get second place in Boston 2 weeks later. So don't go by the MRI. Um, Achilles tendinopathy or tendonitis, there really isn't a lot of tendonitis, but tendon problems. You do eccentric strengthening, you don't do stretching. I'll show you what this is. You use heel cushions to elevate the heels and avoid zero drop shoes or low drop shoes. Shockwave has the highest level of evidence. It should get about 90% of the people better. And then surgery, if it doesn't work after 3 to 6 months, depending on the level of the athlete, will consider surgery. That my published outcomes in the biggest series of the world gets a 96+% of people back to their sport. So surgery is not the end of the world if you need it, but most people don't. So this is the eccentric strengthening. You're supposed to start on a step, but I tell people start on a flat surface and stay on a flat surface if the Achilles tendon problem is down low on the heel. So go up with 2 feet and then take 1 foot off and lower it down to 90 degrees. All you need to do is 3 sets of 10. So 3 sets of 10. And so that's the exercise for Achilles. And the next super common injury are stress fractures, particularly the lesser metatarsals or the not the big toe one. And there's a lot of myths in medicine. As I said, the metatarsal pad is a myth. The metatarsal pad is a lump underneath your foot, and you run with a lump underneath your foot, you'll get a stress fracture or neuroma. And they tell you to stop running for 6 weeks with a post-op shoe. If you walk in those post-op shoes, you'll get an arch or Achilles strain. So what we do is offload it with an insert. We do use Shockwave. We let them run on an anti-gravity treadmill at 70% body weight once the pain and swelling stops, as well as use an elliptical. And then you can ride a bike and you can run in the deep end of the pool, no flip turns. And then you got to look at things like core imbalances and the shoes they're running in, the training they're doing, vitamin D levels. And don't take anti-inflammatories. Anti-inflammatories slow down bone healing, so they're the wrong thing to do for bone injuries. They're the wrong thing to do for stress fractures, shin splints. Stay away from that. And there's certain metatarsal stress fractures that you cannot run this quick, Jones fractures and ones that are further back in the instep. Just so you know, depending on where the bone is, you can usually run if it's down towards the toes. So this is one where her MRI was negative for stress fracture, so she kept running because remember, you let pain be a guide, but she kept running and the bone healed upward. So it's angled up. So now the third metatarsal and the sesamoid bones underneath the big toe become problematic. So don't rely on a stress or an MRI for a stress fracture. So what do? You get the insole, turn it upside down. Whichever bone has got a crack in it in the middle, you can put padding on the sides of it. You can add moleskin. You can do 3 or 4 layers of duct tape and offload it. Do not use a metatarsal pad. One of the most successful runners, he's a very successful coach now. He had a third metatarsal stress fracture. He put a metatarsal pad, and I told him to cut the pad in half and put the pad on the sides. And then he ran a test at in a Nike research lab, and they said, "Oh wow, that makes a huge difference. The other thing didn't really work." So again, no metatarsal pad. And then the other things they don't tell you, they tell you that the sound wave you can only do weekly, but if you have a sound wave machine, you can do them daily for muscle soreness and shin splints, and you can even do it during events. You can use it on growth plates like the heel pain that a lot of early high school kids get, Seaver's disease, that you can use Shockwave for that. They tell you to only use it for like 2,000 or 2,500 pulses, but you can do more. If you're doing a hamstring, you'll treat it with 5,000 pulses. Um, and you can do it pre and post surgery. You can do it before a PRP injection to help. You actually, if you hit the test tube with a shock wave, it makes the PRP more concentrated. And then shin splints, super common, especially in high school kids up until early college. They tell people to rest. They have you do all kinds of exercises and then maybe orthotic devices, but most orthotics are not made to address an athlete, let a running athlete. So you got to make sure it's not a stress fracture or compartment syndrome, which is pretty rare. Um, Orthotic devices, they need correction in the forefoot, so I'll show you that. Anti-gravity treadmill, you can run with shin splints at 70+% up to 90%. If you're at 85 or 90, you can really run outside. And then you use a pneumatic leg brace for impact sports. And then you use shockwave a lot for shin splints. That has the highest level of evidence. We call it periostitis. Periosteum is the covering the bone, so the shin bone gets inflamed. And shockwave is a game changer for that, or sound wave. And then again, just the basic things, look at the imbalances, the core, the shoes, the training surfaces, the vitamin D, avoid anti-inflammatories. So this is an orthotic device, but you notice that the extension is thicker underneath the big toe, and that's key. You need to make the extension help the athlete, because if the orthotic just ends at the ball of the foot, and a lot of sprinting and jumping athletes, they push off on the ball of the foot. So if they don't have the correction in the ball of the foot, it's a problem. It doesn't help. If you're going to have an orthotic, make sure it's an orthotic that works. And then MRIs, again, a lot of times radiologists want to chicken out and not say there's a stress fracture. They just say high grade stress injury. But if it's high grade stress injury, it's basically a stress fracture. There's someone who had a stress fracture of his tibia. Um, and you can even see it on the X-ray. There's like a lump over there on the left. So you got to treat the patient, not the MRI, because the MRI will be abnormal for months after, sometimes 2 years if you drill into it like a surgery. So we use these long leg braces that people use often for ankle sprains, this brand, but they go up halfway up the leg or all the way up to the knee, and you use as high as you need to, depending on where the stress fracture is. And then also you got to consider shockwave, because that can be a game changer. And so here's like the thing to do for a stress fracture. All these things we did is like the 10 commandments of shin splints. And we were able to, this guy had a stress fracture. He rested for what relative rest for 2 weeks. He ran the pool, got on the bike, and then at 2 weeks started running on the Alter G, getting shockwave every other day, or sound wave. And then by 7 weeks, he was running outside. 10 weeks, he won the Olympic trials in record time. And 17 weeks, he won the gold medal. Now, if you had a patient with a standard tibial stress fracture what people normally do, you'd say, okay, you got to rest for 6 weeks, put him in a boot. And so he would never have gotten a chance to even get to the starting line at Olympic trials. So these are things you can push the envelope. I published this, and this is sort of the protocol that I use, and that's safe. I would, I get frustrated when people say, "Oh, I had to rest for 6 weeks, got shin splints or stress fracture." And this is another one. Again, this is another lead athlete in his femur. I don't treat femurs, but I helped some colleagues manage this because they said early stress injury or adductor injury, but that's on the MRI. But you need to get a CT scan if you have suggestions of a stress injury on these bones to make an in-season or significant decision. So when you get a CT scan, again, it shows a crack in the bone. And so this is a stress fracture, even though the MRI just said stress injury. And then we treat it with focused shockwave and PRP, and then it completely healed in 2 weeks. And the orthopedist that was managing him was surprised, but we can see bone healing in 2 weeks using these technologies. So this is a pressure wave, sound wave machine. It sounds like a jackhammer. This is what most people, when they say they have shockwave, they have some version of this. They're about 20 something thousand, but there's a portable $11,000 machine that some of the pro teams have bought. Doesn't go quite as high at energy level, but it's safe for the coaches to use, or the athletic trainers. You really should get training though. There are training courses on it. And then this is the Focus machine that's like $70,000, so it's heavy. You don't want to carry this thing around. Um, and so this goes deeper. It works for soft tissue and bone. And then this is the newest thing, which is electromagnetic field. It's 10 times stronger than a bone stimulator. Some of you might be familiar with bone stimulators. They don't really work all that fast. And so this is actually kind of a game changer, not only for bone, but for arthritic conditions and also for stimulating a healing response and recovery. So a lot of the elite athletes are using the EMTT after hard workouts to help with the recovery. And then can shockwave speed up surgical healing? So I did a quick study looking at pain after surgery and pain and X-ray healing and return to activity, and comparing using patients that had just the standard surgery treatment, and then a group of patients that had the same procedure but had EMTT and the focus shockwave post-op, and we found significantly faster return to activity, actually almost 2 months faster. Uh, Bone healing at 4 weeks, significantly better, and no less pain at weight bearing. So kind of wrapping it up, this is my mnemonic I came up with in 2017. Policed. So I had an editorial, should injuries be policed? So policed is protection, so bracing, insert, tape, optimal loading, like anti-gravity treadmill, ice. You can use that with compression. And you use ice for pain and swelling. You don't necessarily help healing, but it helps with pain and swelling. And then C is the core strengthening. Um, and your foot core, your regular core, education, so exercises and education of the coaching and using evidence-based treatment. And then D, your diet. You look at the intake. A lot of people don't take enough the right stuff or don't eat enough. As you know, REDS is the reduced energy deficit in sport. A lot of women have it, but some men have it too. So vitamin D is critical. 99% of the doctors can't remember that you're supposed to take vitamin D at night. They forget to tell their patients. So if you take it in the morning with orange juice, it's not going to do anything. Just take vitamin D at night, put the bottle next to your dinner table or your bedstand, and just take it with the water. And then shoes. So shoes are the most important equipment. So rocker sole shoes are good for big toe arthritis, hallux rigidus. Low-heeled shoes are good for anterior knee pain. A lot of female athletes get that, but they're not great for Achilles. And then carbon-plated shoes. Super shoes, carbon and other stiff plates. They call them a lot of different names now. TARs, technologically advanced running shoes. They're stiff for more propulsion, so they make a longer stride. So that's why some people get hamstring issues. But if you don't have foot strength and flexibility, the carbon plate at least will not bend. So your foot will have to bend. And if it isn't flexible or strong enough to take the forces, then something will break or tear. And so that's why we use that blackboard to help mobilize and strengthen the foot. Um, the plated shoes have been good for business because I already hold the world record for repairing navicular injuries, and I've been having record years the past couple of years. If you write a graft of people using the carbon shoes and a graft of me repairing navicular fractures, it's probably pretty correlated. So there's increased number of midfoot injuries. And the problem is everybody relies on MRIs and they miss these stress fractures of the midfoot. MRIs are only 70% of the time accurate. CT scan is the best. That's a CAT scan with small cuts. Surgery is actually needed for half the injuries, and they all need some kind of non-weight bearing in a boot at 90 degrees for at least 3 to 6 weeks. And I say 23 and a half, 7. So that means half an hour of a day. You can take it off to bathe and ice, and that's about it. And you can't take the boot off to get on the bike. You can't cheat and sleep without the boot because the foot, if it doesn't get at 90 degrees, it has tension on top of the foot, which is tension does not help bone healing. Bones heal with compression, not tension. So keep that in mind. And this is an example of MRIs that don't show a fracture. The MRI is the this one with the arrow. It doesn't show a fracture. This is the same patient. The image is a little flip, but this is a big crack right there. Same exact patient. This is bad. You need surgery for this. MRI here shows some stress lines, but doesn't show a fracture. But on the CT scan, again, same patient, the bone is completely broken, and you need to have what we call small bone cuts in order to get this. And people rely on the MRI and they miss it. And if they get a CT scan with big cuts, they also miss it. Standard CT cuts are 3 millimeters. You need to get less than 1 millimeter. And this is the article I published in 25 years ago, the classification system for navicular stress fracture. So it's actually named after me. But this article in 2017 kind of lays it all out there, why you need to do what I'm recommending you need to do. And then, yeah, I've been lucky of people I've met and treated, and Galen's been great. He, has had a lot of injuries, and he's going to become a great coach or whatever he wants to do. But he had this line: recovery is not linear. So just keep that in mind. Sometimes you have a couple speed bumps in your recovery process. So I can take questions if you want.
Okay, well, if you have questions, let's raise your hand. I've got one initially is it sounds like this shockwave machine, which again, I've been dealing more with high school of late. And so if we don't have access to that or being limited, what would your recommendations be?
Find a place that has it.
So go away, I mean, go to a physical therapist or something like that.
Yeah, some physical therapists have it, some chiropractors have it. The issue is that you need to have an accurate diagnosis. And sometimes even doctors can't get the accurate diagnosis. So you need to get the accurate diagnosis. So get the accurate diagnosis, and then you can go on to a website, Curamedics, Curamedix. I can write in the chat. I think let's see, where's the chat here?
Yeah, it should be
Um,
down there
yeah,
next to participants.
I got it.
Okay.
So go on there, and I think they have a list of providers. You can also go to a website, AMS, I think it's .com. That they should have a list of certified providers. I'm a certified provider, um, and so you need to find those individuals in your community and get that. And more people should be getting those machines. I was just at a meeting last week where we had 100 people attending. Most people had some form of the machine. So,
Okay. So you said for shin splints not to take anti-inflammatories.
right, correct, because that takes away bone. And if you take away bone, you might get a stress fracture.
And so that's like a Advil or something like,
Yeah, Advil, Aleve, ibuprofen,
is there
Ovic,
anything
Celebrex.
is there anything that they could take to help with the pain?
Yeah, Tylenol and ice.
Okay, great. Thank you. Allison, you want to go ahead?
Yeah, my name's Allison Wood. This was amazing and super helpful. I had a decade of Achilles pain that was taken care of in 5 sessions of shockwave. I also use PEMF, but what about red light therapy? Do you have any experience with
Yeah,
that?
red light works temporarily. It just works superficially. So that helps treat the symptoms. It's kind of like ice, but it probably helps a little bit better than ice. So,
Okay, so would that be good for kid like our high school kids with shin splints?
yeah, it just doesn't really promote any healing.
Okay, got it. Awesome. All right, thank you.
Okay, John?
Yeah, I've got a couple. The first one, back to kind of the shin splint. On the slide and then on the website, I was looking at it too. You have assess core strength and muscular imbalances. Can you add any specifics to those two items?
Well, your core strength, that's all your core. And if you have a weak core, your foot rolls in and your foot's less stable. So that's why you got to work the core. But their foot core is basically doming your foot or working the foot strength stuff. So there's exercise with little different tools in that blackboard also. Um, and people go in the training room, they give them the bands and they do 8 million exercises with the bands and they never get better. So it's not the band work really. I mean the band work's part of it, but it's not the only thing. That's why doing band work alone doesn't work.
Is it for strength splints, is that related to generally an overpronation issue? Or is that just one thing that could cause it, or is that
Yeah,
all?
that's just one thing that can cause it. There's a lot of things that can cause shin splints. So a lot of times it is overpronation. A lot of times it's a beginning runner. A lot of times it's just not enough core strength or foot strength.
And then the other one you mentioned take vitamin D at night. Did I hear that correctly?
Yeah, correct. Yeah, have to take it at night. Doesn't work. Vitamins A, D, E, and K. Those are all nighttime vitamins.
Can you explain that?
Because they're what we call fat soluble vitamins, and your fat metabolism works at night. That's why you're not supposed to eat close to bedtime.
And then, sorry, I got a bunch of them here, but you're answering them quicker than I expected. I'll finish the last one. Have you heard of frequency specific microcurrent? Or have you heard of that or
No,
have any thoughts on that?
no, I haven't. I mean, there's a lot of different kinds of machines and things, but I mean, there's things that help temporarily, but actually things that change the tissue. And keep in mind that when you have shockwave treatment, it can take 12 weeks to notice the effects. So some people say at 6 weeks it didn't do anything, but at 12 weeks they're like, oh yeah, I think it worked. So with shockwave, particularly the more chronic conditions, it'll take 12 weeks to notice the full effect.
Thank you.
You mentioned about that board that there were knockoffs in the US. Are the knockoffs still okay or are they
I think so. I mean, you can ask VJ. He bought a couple.
oh. VJ, are you there?
His
Yeah,
phone.
I got like basically you can get three for the price of one of those. I think it's called Glitz,
Yeah, glitz.
GLITZ.
Yeah.
And the one thing I noticed is that some of the wood is like starting to chip off. I mean, we use them pretty regularly, so I'm sure the other ones just last a little bit longer, but I mean, I can just throw duct tape on it.
Okay.
Yeah.
Okay.
Yeah, I think if you use my name, Amol 10, AMOL number 10, you get a discount. So
Oh, there we go.
10% discount, but
Okay. Veronica, you want to ask?
Yes. So VJ, I'm curious because I'm sorry, VJ, Amal, sorry. I'm looking at the return to run plan on your website and I'm just a little bit confused because when I get down to the more bottom of the page where it says the day and then level 1, 2 by 2 minutes, 1 minute walk, rest, then level 2, what are you using as the progression for that? Is it like Monday 2 by 2 minutes, Tuesday rest, Wednesday then 3 by 2? Thursday, then 4 by 2. I'm just confused about like the sequencing of it, if that makes
are you
sense.
talking about the parameter to begin running? Like
This is
two
below
minutes.
that when it says return to run program at the bottom underneath the bullet points.
Oh, you know what? That is an app, RTR. So that's just the Word file. If you go to the app, sorry, yeah, there should be a link to the app. Um, yeah, so there's an app that Dave Campbell did called RTR. It's
Mm-hmm.
pretty good. It's just a little bit more in detail than so yeah, level two you do. Yeah, I don't know if that's every day or every other day. I don't know. But I just printed that out in case people didn't have the app.
Okay.
Um, but yeah, that should actually under links. My website is going to be totally overhauled because I'm joining a new group. And yeah, the RTR app is in the bottom of
Mm-hmm.
under links. And yeah, I think it's still live.
Yep.
Um,
Do you have anything else, Veronica, or is that it?
Yeah, so I know, Dr. Saxena, you were also talking about earlier that when people follow your return to run, that they haven't been injured before. Is it following the RTR plan at the bottom or more the table
the
on
table.
the table? So that means they're doing a 15-minute run continuously on the first day?
Look above that. It says first you do 2 minutes on, 2 minutes
Hmm.
walk 4 times, and then three
Yep.
minutes on, 1 minute walk 4 times. Then if they do that, then they start the 15-minute continuous.
Okay, got it. So they do the run walk, but for
Yeah,
how
and
long do they do the
this is
walks?
obviously more for distance runners because
Right.
sprinters are going to be doing this kind of
Yeah.
stuff. So
Yeah.
15 minutes would be too long for them.
Yeah, yeah. I guess I'm just confused about how often they should be doing the run walks before they get to 15 minutes that they're doing each day continuously.
Oh, just you can do that every other day. But if you're fine with 2 minutes on, 2 minutes off, then you just go to 3 minutes on, 1 minute off, and then with a rest day in between, and then with a rest day after that, you should be able to start running.
Okay. Okay. Thank you.
Great. Marcia?
Two things. Yeah, we've had tremendous success with our podiatrist in town with the shockwave treatment with several of our athletes with particularly plantar fasciitis and Achilles tendonitis. So we're very fortunate.
Yeah,
My
who's that? Who's who do you work with?
uh, our podiatrist is John Zimmerman
Oh,
in
are you
Bakersfield,
Penn
California.
State?
In
Oh,
Bakersfield,
oh yeah, yeah. Oh yeah, yeah. Okay, yeah. He's sent me some
yeah,
patients. Sure.
he's fantastic. We can get people over there really quick, and he's just always willing to work with them. And we've had people come back from pretty nasty plantar fasciitis and miss very little running.
Yeah, well, you can keep running while you're getting the treatment. That's the
Yeah.
great thing about it. So.
Okay, my question is, and I don't know if this is total crap or whether it actually helps. What about night splints for plantar fasciitis, like an ongoing thing? I've had some success with athletes that have used them, but I don't want to screw people up.
Yeah, so night splints do help, but primarily they help with the morning pain.
Okay.
So, and you got to be careful you don't overdo it because again, runners oftentimes overdo it, and so you don't want to stretch the nerve. Some people overstretch. So,
Okay. Thank you.
yeah.
Okay, any other questions? I know you guys usually have plenty of them. Well, you'd mentioned about the trainers, and I know that that's a political question sometimes, and I've run into it at high schools and at universities, and I agree that, I I don't have a high thoughts of many trainers. There are some excellent ones, but some that I don't know where they went to school. But
Yeah.
do you have any suggestions on how we as coaches can advocate with trainers to be more current with situations or how to advocate better to get better treatment?
Yeah, I mean that is a sort of political and an ego-driven thing, unfortunately. There's a lot of prestige in being the team doctor and sometimes the trainers are aligned to the team doctors or not aligned to the team doctors and there's also ego. It's usually the least trained person is the gatekeeper. And I think I think they should understand that they should be on the team to try to get you better. And, my definition of sports medicine is getting you better as soon as safe as possible. So I've shared with other trainers some of my publications. I've got a chapter on stress fracture of the foot that basically is a guideline how to treat every single stress fracture in the foot. Um, but if they don't want to release the patient, I think if it's a high school kid, the parent should be making the decision more than the trainer and the kid. I've talked to VJ and I've talked to other college coaches that you can it's okay to get the advice and also seek another opinion. That they shouldn't be that shouldn't hopefully be too offensive to them. Um, and then um, some of the trainers want to get training. They can go to the courses that I teach. They can, do online stuff. They can access my stuff. What I'm going to start doing in my new practice, so starting June 3rd, is have something called an Elite Access Pass. And part of the reason is to protect you as a coach. And, I get asked to review MRIs of some athlete that I've never seen before. And there's a little bit of liability or a lot of liability in that. And my time is also valuable. With NIL deals and scholarships, if you as the coach say, "Hey, I sent I sent your MRI to Doctor So and so, and Doctor So and so doesn't think you need to rest, or Doctor So and so thinks you need to do this," um, that kind of puts you on the spot too. And again, with scholarships and NIL deals, I think it's important that this stuff gets documented. And I actually did an MPH at Dartmouth, and one of the things that one of my MPH projects was researching license reciprocity, or being able to practice across state lines, which you're allowed to do with telemedicine right now through September. It happened during COVID, and they keep extending it, which hopefully they'll extend it indefinitely. The other thing that if you're a team doctor, you're allowed to go across state lines. But starting June 3rd, myself and a couple other docs are going to start this Elite Access Pass, and basically we're going to charge $365, so $1 a day, and you send it in, and you send the stuff, and then you can text or email or whatever, and we can give you advice. We can give you basically consulting or coaching advice. Because it's not fair to me, it's not fair to the coach, and you want to document everything, and that way I or other specialists can look at this stuff. So I'm seeing if Adam 1040 can do that with me, because he's in a big group. I left a big group, and I'm just going to be on my own. But that's something that we're going to start, and you can have a conference call with the trainer right there, with the athlete. I do a lot of telemedicine with the patients who come from out of state, and they're in with their PT or their trainer, and we talk about the rehab program, what you need to do, and it's worked out really, really well. So anyway,
Yeah, will
that's,
that be on your website as to how to access?
yeah, I'll just have a Zelle account, and yeah, so
Okay. Yeah, because that's the thing I run into is, these little aches and pains, but they're affecting performance. And then we have to go through all these steps that it takes time and time away from the competing. So it's very frustrating on on my part, or the coach's part at least. Uh,
yeah.
what would you say are some things that we can be watching for to prevent overuse syndromes, of whether it be running or jumping or sprinting? Are there key signs that we should be more aware of?
Well, you don't want to get to the point where you're getting pain accompanied by swelling or limping, so you don't want to go there. So, I mean, one of the things you can do is just monitor their perceived exertion or perceived pain, and again, keep it under a 4. And high school kids, the classic thing is high school kids haven't run all winter, and then they start tracking end of January, and their shins hurt in the first 2 weeks, and they say it's overuse. That's not overuse, that's underuse. Because they haven't been using it, and your bones are getting used to the stress, and their bones are growing, and so that's why they're getting stressed. Um, so I would do the things like the strengthening exercises and address the shoes and inserts. And if they start getting problems where they're getting 4 more out of 10 consistently, those are the people that you should, connect them with somebody that can get them diagnosed and hopefully treated with shockwave or sound wave.
Mhm.
And so you don't wait. So the problem is most doctors, if they say it hurt, you tell them it hurts when they run, they'll just tell you not to run. And shutting down a high school kid for 3 to 6 weeks, they basically lost their whole season.
Right. Right. Well, what about, is there anything like the athletes that don't do things in the winter or the fall? Is there anything or kind of a progressive foot strengthening plan that,
Yeah, so that's when they use the blackboard and do the foot doming, the exercises. They do that as part of their routine. We usually have the kids try to do core strengthening at least around twice a week.
Mhm.
We have, they can have do barefoot strengthening. I totally think it's important to do barefoot walking and even strides to build up the feet. So, and I think it's important to kind of do a little bit of stress year round. I mean, obviously, you take usually a week or two off after each season, but um, you need to keep moving and keep the system sort of running with strides throughout the year, and then that way the graduation into or the initiation of actual speed work is not as stressful.
Mhm.
And
Yeah.
the wintertime, the track's a little bit harder, so their shins will get more shock. With the carbon fiber shoes, plated shoes, we tell people to use them as a training tool, like a spike. You don't run in spikes every day, or you don't even run in spikes 3 or 4 times a week unless you have 3 races in a week, like we did a couple of weeks ago. Um, so you use those carbon plated or technologically advanced shoes, use them as a training tool. So you do part of the workout one day a week, and then you do more of the workout another day of the week. The thing with the carbon plated shoes, they were designed to race on the roads, and you're talking about people racing on a track or cross country. So those are soft surfaces. So if the soft surface is really soft and the plate is unyielding, you've got unmitigated stresses really just kind of limiting the foot. And so that's why, those shoes were designed again to run on the road, not on the track, not on a cross country course.
Interesting. So did people just take it to the track just because of the fast
Yeah,
time?
they feel better. They recover faster. They feel like they run faster. I mean, you do run
Interesting.
faster. So
Interesting. Now you had mentioned about navicular injuries, and I know that used to be a almost career-ending injury.
it still is.
It is? Okay.
Yep. Yeah. I
So,
mean, like I said, I hold the world record for fixing them, but I mean, I haven't had too many people where it's been career ending other than a very famous Spanish basketball player, but he was over 40 anyway. But yeah, naviculars, the problem is they don't get diagnosed right away and they get missed on MRI. It takes on average 9 months to diagnose them, at least in the study I did in 2017. So they keep running on it, making it worse, wearing out the cartilage, getting arthritic changes. And then the other thing is that if they had, there's 4 classifications of it. And the type 2 and type 3 are the worst. Type 3 is a complete fracture, and type 2 is an almost complete fracture. And those pretty much do not heal unless you have surgery. And naviculars, if they're any navicular, they often don't heal, re-break, get arthritic, and or the athlete gives up their sport. So all 4 things are bad. So you think 3 strikes you're out. Well, there are 4 conditions that can knock you out. So that's why you need to have those CT scans with small bone cuts, and then you need to have, if you need surgery, you need to have a surgeon that knows how to operate on them. I've taken a couple people back to surgery that had other surgeons that did their surgery, but they didn't do it right.
mhm.
They could read my stuff easily, but they did it a different way, and they didn't heal, or they rebroke. So that's why I have a lot of out-of-state naviculars. I probably put more screws in people in the state of Oregon and Arizona than anybody else in the navicular. So
Oh goodness. Yeah. No, like I say, I remember that was like the kiss of death if that was a diagnosis back.
Yeah, but if you have, I mean, I had three patients or four patients in the Olympics competing and one in the finals of 1500 that I put a screw in. So you don't, it doesn't have to, and I put the screw in her in high school.
Oh, okay.
They've, a lot of people that put screws in have gone on to do better things.
Do you find different injury patterns with male and female, high school or collegiate or pro?
Um, in track and field, not so much. Definitely in other sports. The main thing is that if there's disordered eating or not enough, Redd's phenomenon, then you have delayed healing. But the injuries are pretty much the same. So,
Okay.
and I see traumatic injuries too. I mean, I see Achilles and plantar fascia ruptures. So I see a lot of traumatic injuries. So.
Yeah. Veronica, what would you like to say?
Yes, so my question is, I had a student athlete who had pain on her shin. Unfortunately, she was not able to get an MRI just with the insurance provider that she has, and she's been able to do a return to run and it's all fine. I'm just curious in your experience because she's now more or less pain-free. She says she's feeling pressure just because I think she's more anxious about it, and I don't know if we'll be able to get an MRI at this point again with
Well, the MRI won't help at this point.
or cat. Yeah.
Yeah,
Yeah.
MRI.
It, yeah.
But if she gets pain that gets worse with running, then that's not good. If it gets better as
Right.
she runs, that's good.
Okay.
And
Okay.
you have some awareness pain, even when you have a stress fracture. When you get running, just even on metatarsal, you feel it with the first couple minutes of the run, but then it should go away. If it
Yeah.
gets worse as you run, then the stress fracture hasn't healed or the shin splint hasn't healed. So, but the great thing about the shockwave, and technically when I'm saying shockwave, most of the time I'm using sound wave. Kids get right off the table and hop on it before hopping hurts. And if one of the things we tend to use is the hop test. If you hop 3 times, it doesn't hurt, you can run. If it does hurt, you can't. But they get the hop test, it hurts, and then they get the sound wave, and then they get off the table and they hop and it doesn't hurt. So that's why it works quite immediately. Um, some of these kids, just because of the whole anxiety thing, they get nervous about shockwave because they think they're going to get zapped with electricity, and there's no zapping
Right.
that causes pain or anything like that. So,
Yeah. Yeah. So I know you were saying earlier, like, don't let pain be your guide because these athletes can be so stubborn. So do you feel like, again, if their pain is not increasing as they continue to run further, then it's safe to continue in a return to
yeah, as
running?
long as it's under those parameters, doesn't hurt, it doesn't get worse as they run, doesn't cause limping, doesn't cause pain and swelling. It's under a 4 out of 10.
Okay. Awesome. Thank you.
Now, the rest of you are being pretty shy tonight, so I'm just going to keep asking until these hands come up. So please do ask. Great. Jana?
Hi, so I have a question. I had a student athlete who was super consistent with running. He cycles through shoes. He kind of does everything right with warm up, cool down, all that. And he started getting like a random shin pain. We thought it was shin splints, and we kind of put him on a shin splint protocol. And it just wasn't getting better. So then at one point, we just took time off. He was a transfer student, so he hadn't arrived at the university yet. He only does cross, no track. I think he took 3 or 4 months off, and there was no relief to the pain. They did an MRI and an X-ray to rule out stress fracture. We thought it was compartment syndrome at one point. He had a Doppler scan. It wasn't compartment syndrome. Still,
Doppler wouldn't work for compartment syndrome. Doppler works for something called popliteal entrapment syndrome, which is pretty rare, but I see it about once or twice a year.
okay.
Compartment syndrome needs to be measured with compartment pressure device, which is kind of a big needle and scary.
Yeah.
But they are very similar. Compartment syndrome gets worse as they run, and then when they stop running, it goes away within 5 or 10 minutes. Popliteal entrapment syndrome gets worse as they run, also feels like cramping, but usually the hole starts in the back of the knee and then works in the front of the shin. And
Okay.
that might linger for longer than 5 or 10 minutes.
Okay. He said, because he doesn't do track with us either, he's just strictly cross. He's going through his clinicals for student teaching right now. And he said, even just standing around, he's feeling the pain. And so I feel lost because he's starting to get demoralized, and I don't know which direction to point him or what else we can do. We've tried insoles, we've sent him to a podiatrist. Nobody really has an answer for us.
So he has pain when he stands.
When he stands, sometimes even when he lays down, with activity, without activity. We're coming up on his senior year, and he's gotten to the point where he's like, if I'm in pain 24/7, I want to just push through it. But I'm thinking
Is it
long term.
localized to one area, or is it like his whole front of the shin, back of the calf, or both?
The entirety of the shin, like the whole front part. Sometimes he complains about calf pain, but not often.
And they did a Doppler. Did they do it under stress, like try to have him do like a bunch of heel raises and then measure the pressure?
That I don't know. I know he had to fight tooth and nail to get the Doppler. We're also up in rural Iowa. So they talked about sending him either down to Des Moines or up to Minneapolis to get some more tests ran. But I haven't heard anything since.
Okay, I can ask a friend of mine who has his kids go to Iowa State. I think it's Iowa State. Because he comes, I think he has privileges there or license there.
Okay.
If he could examine him. I mean, it sounds like it could be a vascular thing because with standing, you get what we call dependency, or the blood just rolls downhill.
Yeah.
But they might have to do like a stress test of it. So
Okay. Thank you.
Did you had mentioned at the very beginning about anxiety and foot pain?
yeah, 80% of people with chronic foot and ankle pain have higher levels of anxiety and depression.
So is that again, is that something then that we just try to alleviate the anxiety or
Yeah, I mean, I don't know if you have access to sports psychologists. I mean, the psychology profession is probably inundated with people with anxiety.
yeah.
I mean, sometimes, coaches are parents, trainers, teachers, therapists.
Mhm.
Kind of have to use. There's a website called Skylar Health. I thought I had a link on my website on it, but I don't think so. But let me just see. And spelled Skyler Health. And they've got a whole thing for I guess I don't have it on here. Um, they have a whole thing for uh like sports injury, depression. They don't call it depression, but
Mhm.
sports injury or post-op pain is how I have it, because some people after post-op pain get, all worried and they're never going to get better, and why am I still having pain and all that. So there are two portals that they can use, and again with telemedicine they can go across state lines, and they do take insurance. So
Okay.
so that might be something. Yeah, it's not, the link isn't on my website. So.
Okay. We can track that down with that. You had mentioned also barefoot running. Are there any any things we should not do barefooted or what are
Well,
some
you never see a Kenyan running barefoot on concrete. So, yeah, don't run on hard surfaces.
okay, so soft surfaces barefoot.
Yeah, the field turf is perfect. Even a track that's doesn't have a lot of grit on it is okay, and good grass. So
What are some recovery methods or protocols that you would recommend, let's say for a high school kid, um, after workouts?
after workouts,
Yes.
well, high school kids just bike home. Yeah, that's the recovery. But I mean, I don't know. Some kids, rich kids have, or rich schools have Normatec boots. Nike has those new Hyper Volt $900 boots. I think they're on sale for under $300 on some website. So,
I mean, are those any value, the compression or the
Yeah, those compression are
gun?
good. Yeah, yeah, they're good.
How about massage guns? It seems like every kid has.
Yeah, massage guns are good. Foam rollers are good. Those are good ways to warm up and recover.
Okay.
They
What
got good massage guns for like 60, $70 now. So,
yeah, that seems very accessible nowadays. What are your thoughts about warming down?
well, again, they're biking home, but yeah, we have them do a cool down. They jog easy for 5 to 20 minutes, and then they sometimes stretch, but they usually just get home and do their homework.
Okay, well, around here,
Yeah, the thing is, warming up is probably more critical than cooling down, but um, again, stretching is good for kind of improving the range of motion,
mhm.
but doesn't really help with injury prevention or healing.
Okay, yeah, because kids around here pretty much ride buses or drive. There's not a lot of bike riding, so that's why I didn't know if there was something that,
Yeah, getting right on a bus isn't probably the best thing,
yeah,
so yeah, probably cool down. Yeah.
yeah, because they live many, many miles away sometimes.
Yeah, then probably it is good to do a cool down. So
Okay, you had
or
mentioned,
get off one bus stop before their regular bus
well, there
stop.
you go. That's it. Do that. Um, is there an underrated injury prevention method that you would suggest that we not, I mean, that we use more of to prevent injuries? Is there something we should be doing more of?
Underrated?
Yeah,
I don't know, probably just with high school kids emphasize sleep
yeah, yeah,
and a decent diet. I mean, a lot of people want to be vegan or vegetarian, and you just got to make sure they're getting enough protein. You know, if the kid's performance is starting to slack as the season goes on, they're usually anemic. So, every state's different, but, some states they don't want you to tell them that you should see a doctor, a nutritionist, or take iron. You can only give so much advice.
right.
So, I mean, bringing it up with the parent, but, the parents, we got a parent generation right now that's a little bit difficult too. So, yeah, there's not a lot, unfortunately, the respect for coaches and teachers like they should have. So,
That's for sure.
especially in Palo Alto because everybody's smarter than us. So,
No, well, that's the thing is so many of parents, are either think, like you say, they think they know everything, or they're trying to
yeah,
set,
well, so what you can do is redirect them. Say, okay, you're looking on the internet. Well, go see this guy's site. So,
there you go. That's a good idea. Yeah, because I've got some that I would like to lock up somewhere, but we'll see about that. Coaches, we got about 5 minutes left. Do you have any last minute areas that we haven't covered that are of interest to you and or to your students? Marcia,
Sorry. Yeah, one more question. In this age of like the high stack shoes, and I ran when basically they were those old Asics Tigers that were basically ballet slippers.
okay.
Um, what's your feeling on the minimalist shoes as opposed to the, I call them marshmallow shoes now. So I usually get the athletes because I coach at a university, so I'll get the distance kids one what I call a marshmallow shoe, and then one that I'll have them use for like tempo runs and intervals because I don't like to work out spikes very often at all, if at all. But you see those. I don't know. There maybe it was like 15 or 20 years ago. There was that thing in that barefoot running thing, and they were
Yeah. So, I
basically
mean,
the shoes. And I was meant to ask a podiatrist what your opinion on those were.
yeah. So use those for strengthening, but not for actually running in. So I don't think they're really great for running unless you're on a, grass, like the stuff you do barefoot. So you might as well just be barefoot.
switching sports to basketball, those shoes that they had for a while that where the heel was elevated and they
Yeah, to jump. Yeah, I think BJ had a pair of those actually.
what are your thoughts on that?
Yeah, I mean that's supposed to strengthen your Achilles tendon, but that's why you do the eccentric stuff.
Okay.
So
Okay.
yeah, eccentrics, plyometrics, those are all things. So.
Right. Okay. Veronica?
Do you have a preference of which type of shockwave therapy to use on student athletes? Because I went on the websites you recommended. They're using all the different acronyms seemingly interchangeably from what I'm seeing.
Yeah, they're not interchangeable. I'll give them that feedback. I think most of those websites are for doctors, but they're trying. Actually, today we got an email about what articles should we post, and which ones to use when. It's also I have a similar talk on boots because I just had a kid with an ankle fracture who had a short boot, and I have a talk tall boot, short boot, post-op shoe, when to use for what. So shockwave, same thing. So again, most people have radial sound waves. So if they have, a hammer, everything will look like a nail. So they'll use that for everything. But as you get into more expensive machines, you'll use different ones or a combination of all three. I think Curomedics likes to call it the vibranium package. Um, and so you can use all three for certain conditions, but some conditions it's not value added to use, like say the radial, the sound wave machine for a bone thing. You don't need to use a radial machine for that. But all three machines are totally safe to use on kids.
Right, but so you're saying radial is not effective for bone injuries.
No, I mean you could use it for bone, but it hurts and it's not that effective. So
So what's the most
you,
effective one for bone?
the most effective one, if you pick one machine, is the focused one. But the EMTT also helps with bone. But the focus is actually they use in Europe for non-unions, non-united bones. You're not allowed to take someone back to surgery in Germany and Austria because the focus shockwave works about 86% of the time. So um, I don't know if that answered your question.
Yep, that's helpful. Thank you.
Great.
Hey, I have a question.
Sure. William?
Hey guys, I've been dealing with plantar fasciitis for 6 years now, and I've
Six
tried all the
years.
yeah, I've tried all the conservative treatment options. I mainly did the cortisone for the longest time, but I've done a few rounds of that,
A few,
and
like
most
more
people,
than three.
three for one year, and then three a couple years later.
Yeah, you had too many. And you never tried shockwave?
I tried wave when I kind of originally had it. It was one of the more the jackhammer types
Yeah, that's the sound wave. Yeah, you should. Where are you located?
in Tyler, Texas.
Okay. Yeah, I
I know a
rarely
guy now.
operate on
On
people, but the only people I operate on, and it's about 3% of the people with plantar fasciitis, almost exclusively the people I operate on are runners, soccer players, and tennis players. So if
Yeah,
you've
I'm
had
just
something, if you had plantar fasciitis, you had cortisone injection, shockwave, orthotics, and relative rest for 6 or more months, I actually had a statistic.
I,
If you've had it for more than a year and a half, you might actually get less likely to get better even with surgery because your brain is wired to feel pain and walk a certain way. So you need to get on it. I mean, you shouldn't have it for 6 years.
I most recently tried a PRP injection, and when it was under ultrasound, the doctor uh, saw it. He said I had a tear there. He said
Yeah,
about
I mean, a
25.
lot of people may have a tear, but you don't have a tear for 6 years.
Yeah,
I
the
published an
MRI never
article
showed
on
that.
tears in athletes, and they usually heal in 9 weeks, and almost no one needs surgery for that. So
Yeah,
PRP
looking at a
PRP does not work that well for plantar fasciitis, especially chronic plantar fasciitis.
I'm seeing a doctor in Dallas next month. I'm trying to avoid the plantar release surgery. I've heard that can be pretty bad for runners.
I've operated on people who run the Olympics after, so I don't think that's true. Um,
Okay.
Over 100 people that probably 70 are runners. So
Yeah, I've heard both, so I was just getting your opinion on that.
yeah, I mean, when
Maybe.
you're on the internet, you're only going to hear the people complaining. It's like Yelp, right? So
Yeah.
So you are going to see someone in Dallas?
And I found a doctor in Dallas that I think might help.
Yeah, 6 years is a long time, definitely.
Yeah.
We'd have that checked. Um, Dr. Saxena, one of our coaches asked about getting a copy of the PowerPoints. Do you do that, or are those your property?
Well, they are my property. I can
Right.
save it as a PDF if you want.
Okay, okay. Maybe whatever's convenient for you, or if it's not, you know.
Yeah, I can save it a PDF and then email it to you.
Okay, awesome,
And
awesome.
then you have it recorded also, so.
Correct, correct. Well, great. Well, thank you so much. I know I got a lot out of this, and I think the coaches were frantically taking some notes here because, like I say, we deal with all these little aches and pains, and if the kids have it and aren't performing, it affects them, it affects us, and ultimately we want them healthy. That's the main thing. So, appreciate your time tonight, and definitely going to keep eye on the website. His website is fantastic, you guys, and now it's
Well,
going
it'll
to
be
be
better.
updated.
Be more functional. I'll have videos on there and more information. So
Oh, wow, yeah. So definitely, and it's just your name
yeah,
dot com.
amolsaxena.com. That's it. Yep.
Okay, great. Well, thanks again. I sure appreciate it. I know we all do, and um, keep taking care of those naviculars, definitely,
All
for the
right.
world record.
All
Okay,
right.
thanks a lot,
Thanks. Yeah.
everybody.
Bye-bye.
Bye.